So it's a multidisciplinary team effort across not just one part of the healthcare continuum, but across both primary and the support of secondary care. And that brought in a unique perspective to it, because many different clinicians with different specialties came along, mirroring probably the better needs of patients who are usually multimorbid when they have cardiovascular disease. So the Healthy Hearts project was delivered by the Yorkshire and Humber Academic Health and Science Network in partnership with West Yorkshire and Harrogate Health and Care Partnership. And that's working with local NHS organisations within Leeds, Wakefield, Harrogate, Northgate Cleves, Greater Huddersfield, Bradford and Craven.
So as you can see, the programme has involved many people, and I need to thank everyone involved, because if we look at our clinical leaders, a lot of people have taken on this work above and beyond their day jobs, and without any clinical leadership roles or additional jobs as such like that. If we look at who's actually been involved with this, we've got primary care leadership, so place-based leads from primary care from different CCGs. We've got secondary care experts from cardiology, from diabetes, nephrologists. We've even got a specialist from hepatology, particularly when we were looking at lipid management. So it is a vast array of clinicians from primary, secondary and tertiary care. But it's not just about the clinicians. Clinicians are really good at creating the guidance and perhaps giving direction. But we really need a really good management team behind us. And that's why we've got an extended team of public health colleagues, data quality managers, both within the NHS and outside the NHS, and then programme leads or officers on the ground, as I would say, who have actually been our sort of tentacles, imbibing and implementing all of these changes and supporting us in primary care with enacting all these changes. And then we also need to look at industry. And why is that crucial? Because industry has been very helpful and supportive in a way, amplifying the education for us, how we've reached primary care or even wider across our regions in terms of generic education, whether that's around diabetes, around CVD, or even if it's bespoke around our Healthy Hearts project. So again, industry has been very critical for us in terms of amplifying our message to reach the audiences in primary care. A wealth of resources has been created by Healthy Hearts, and this pulls together local resources that we've created either within primary care or from our secondary care teams, but also in terms of national resources from national websites, including the British Heart Foundation or other cardiovascular societies. And what's important is that these resources are all in one platform, the West Yorkshire Healthy Hearts website. And also, more importantly, in terms of our ethnic diversity that we see within our population, we have these resources available in different languages. So for me, one of the brilliant advice to colleagues would be not to reinvent the wheel and actually just use resources that we already have tailored or made bespoke for different populations.
Well, there were three main strands of materials that we produced. So the first was a one-page A4 summary of our guidance to provide a readily deployable and easily accessible guideline for identification and treatment initiation for colleagues in primary care. The second one was access to patient resources. So we provided patient-facing materials which were available on the website and also provided in multiple languages. And finally, we provided resources to primary care colleagues to allow them to perform searches through their practice datasets and identify patients who would be applicable for initiation of therapy. And this was all supported also by pre-prepared letters that could be sent to patients to reduce the workload in terms of driving the project forward.
So I think many of the key challenges are right from the inception to getting a guidance through different committees, budget models, taking the clinical community and that consensus of different opinions to actually get to one position where we are all happy and how it's evidence-based. So I think going through various committees has always been a challenge, and that takes time, it takes effort. You get drawbacks, setbacks around budgets, because a lot of the drugs or therapies that we wish to use, particularly in diabetes and high CVD risk groups, these are high-cost drugs. So when you apply that over thousands of patients that we have across our health system, the budgets can start going into the millions. And even to the end, in terms of once we've got a guidance agreed, for me, you know, the fruit's in the pudding in terms of the guidance is of no value until it actually we embed it and implement it. And I think for me, that in itself was another journey in terms of how we pick up guidance and support primary care, support our colleagues in implementing these changes. And that's why we spent a lot of time on developing searches, identifying patients, and developing resources and patient letters, educational webinars, bespoke webinars, and really reaching out and face-to-face meetings with many colleagues across the region. More importantly, we've developed along that journey is you know, Healthy Hearts Champions, Healthy Hearts Awards, to keep that engagement, to keep that motivation going.
So it was very important in the environment that we had at that time, in the absence of PCNs and ICSs, is that to bring people together and have a bit of a consensus about what we're doing. So having clinical consensus group was really important, where we debated different elements and we managed to agree on what the best way of writing certain guidelines, how we're going to practice. It meant that sometimes we came up with something that is practical, pragmatic, something that is more relevant to the region, something that our primary care colleagues are comfortable with.
The diabetes phase of the Healthy Hearts study, because it was a Healthy Hearts project, focused on patients with cardiovascular disease or high cardiovascular risk. So this was not intended to replace local diabetes guidance, but it was designed to identify people with high cardiovascular risk and look at how we can optimize their diabetes therapies in order to reduce that risk. And at the time we wrote these guidelines, then this was before NICE guidance had been updated to include the data from the cardiovascular outcome trials for some of the newer classes of drugs. So we did meet a little bit of resistance in terms of pushing this through, and had to have discussions with primary care colleagues and with commissioners and pharmacy groups in order to persuade them that the data was robust and that we were all convinced that this could improve the health of our population.
My top tips would be, number one, to think about leadership. Such projects will need leadership. And in this leadership, it needs a lot of collaboration and inviting like-minded people who believe in that cause to come and work together. We need to be a bit pragmatic and realistic by understanding what's the baseline data, where the gap seems to be, and then set our targets where we want to get to and have a clear plan how we can do it collectively in order to achieve it.
We need like-minded people who all need to arrive at the same page, look at the same evidence and come to the same conclusion. Once you've done that, you've probably tackled the first order, which is agreeing on a consensus piece or a guidance. I think after that, you need multiple friends across commissioning, across meds management. And one of the things which I think is key is you need a network. I think it can be a lonely space as clinical leaders, as you would imagine. So I think having that fraternity would be really key to this. For me, one of the first things would be is to reach out to each other as ICS leads, creating small groups, sharing ideas and thoughts around population health management, different tools, and I think that becomes your consensus piece.
What I learned from this program as a cardiologist was that it is possible to develop a population health-based approach across a region, which can be readily rolled out and lead to real benefits, real tangible benefits within quite a tight timescale. And the other benefit I recognised as a secondary care physician was that I learned a lot about how primary care works, and I integrated and worked very well with primary care colleagues, commissioners, pharmacists, and the whole patch. And I thought that was really useful for me to know what's happening in primary care in our region.
We started to learn a little bit more about the differences of the way we work. For example, the medicines management teams across different localities were slightly different to their take on different things related to the cardiovascular disease burden, tackling cardiovascular disease burden. On the other hand, we kind of came to learn a little bit more about the commissioning process and how things are being commissioned, different parts. It's probably, though it was before the ICS came in, it was probably a very good exercise to have a feel of how we can work collectively later on as ICS in order to deliver better care to tackle cardiovascular disease.
We've been on a journey, so there's lots of learnings here. And for me, one of the biggest things that we could do to support other areas would actually be, if you want to tackle cardiovascular disease within your area, let's try to start having conversations around how we can lift and shift things, how we can support you on that journey. If you get stuck with different things, we probably were stuck at that point, so we might have had a few solutions that we could share with you. So if my colleagues are inspired and motivated and excited by our Healthy Hearts journey and what we have managed to achieve in terms of patient outcomes and CVD and tackling CVD across the region, then please do look at our resources. Please do reach out to us. Have conversations with our clinical leadership team. Look at our West Yorkshire Healthy Hearts website for lots of resources.